Thank you, Niall. Thank you, Colin, for asking me to speak at this seminar. I'm a psychiatrist by background, and I have been involved in a project in Southwest London over the last 2 years in trying to address some of the issues and challenges that we have heard about today. The words that Aggie Lewis used ring in my ear. That it's time that we do this work ourselves. And that's a very apt summary of where we are at. Over the last 40 years, we have waited for the National Health Service and the government and responsible authorities in this area to address the problems around racism and inequalities within mental health services, including the brutal deaths of people while in psychiatric custody. The story goes back a long way. While Ajay and Marcy are carrying the torch today, there were people before that who raised the same issues with the same passion and commitment, mostly women who have lost their sons or their partners or their fathers within the psychiatric system. I remember Clara Buckley, whose son Orville Blackwood was similarly killed in Broadmoor Hospital. And that was more than 25 years ago. I remember Rocky Bennett, who was also killed in exactly identical fashion in a place that is called a hospital, a secure hospital, but which functioned more like a prison. And several other people, a list of over 15 people who have died in psychiatric custody, experiencing what we call psychiatric care in the same way. And we remember them because what they told us was the story that is being repeated time and time again in this context. Unfortunately, nothing has happened over the last 40 years. We have had several reviews, studies, and authoritative reports making serious recommendations how things should change. On the last count, there were over 90 such recommendations. To date, less than 15 have been fully implemented. I, as a psychiatrist working in this area for a long time, very much part of the system, I have lost faith in the ability, capacity, or commitment of our system to make the changes. Our communities need to step up and do it by ourselves. We are not going to change things by having further reviews or frameworks. We are not going to change things by measuring it again and again. We are not going to change it by talking about it again and again. We got to do things. And that's where this particular story starts, in Wandsworth, in Southwest London, where the local communities and local people got so fed up with what was being offered by the local mental health system, they wanted to take things into their own hands. They pushed, they campaigned, they eventually succeeded through a community organization taking the lead, Wandsworth Community Empowerment Network, led by Malik Gul, who has been campaigning in this area for the last 15 years, eventually brought the statutory sector, the local trust, and the local commissioning group onto the table to talk about how we can change the system, not through further reviews, or not by looking at the same old data that tells the same old story again and again, but we're taking practical actions. And the project that I'm involved in, called Ethnicity and Mental Health Improvement Program, is part of that. And within that, what I want to focus on today is a particular intervention that is aimed to reduce the use of restrictive practice within psychiatric setting, and also detentions under the Mental Health Act for people from Black and minority ethnic communities. It is a very simple concept that we are trying to pursue, but it's based on solid evidence. One of the things that I want you to think about is that there are places in this world, not far from here, where they never use restraint within psychiatric settings. Not far away, in Italy, in a place called Trieste, for 25 years, last 25 years, they have never used restraint even once, although they deal with similar kinds of difficulties that are presented to them by people from the local population. Their use of forcible treatment or detentions under the local Mental Health Act is one of the lowest in Europe. No one in this country asks the question, if they can do it in Trieste, why can't we do it here? What is it that they've got right in Trieste that we are not even considering in this country? What can we learn from there that can translate into practice here? If you look through the evidence in this area, you can see that restrictive practices, use of force within psychiatric setting is entirely arbitrary. But it is used disproportionately against people of color, particularly people of African and African Caribbean heritage. What happens within our psychiatric system encapsulates what happens across the society. What happens in psychiatric system is not a reaction to the particular mental health needs or care needs of people from Black and minority communities. It is simply a transaction of racism and racial stereotypes that are constructed and sustained within the psychiatric system. How do we address this in practical terms? Well, first thing that we suggested was that we should be party to the decisions. Our community should be present when these decisions are being made. Psychiatric hospitals are closed spaces, increasingly closed over the last 20 years. Entry into these places is heavily controlled, especially for families and the local communities. By ensuring that community members participate in these decisions along with the patient and his or her relatives is the first step towards actually opening up this process. What we are going to be doing in Wandsworth, in the local mental hospital, is just that. We are ensuring that every decision that is going to be made in relation to restraint, in relation to seclusion, in terms of forcible intervention of any kind, that will be shared with and involve a member of the family. It'll also ensure that in those people who do not require or want their family to be present, we are recruiting people from the local Black community, ordinary members, ordinary citizens in the community, and providing them with the necessary training to be part of that process where a decision is considered for forcible intervention. No individual can be subjected to restraint before that individual has a chance, an opportunity to make contact with that nominated person from the community or his or her own family. And that person, we will ensure, will have to be present in the inpatient setting where these decisions are being considered. 80% of the decisions leading to the use of restraint is preceded by a period when things build up. It's only very rarely in the psychiatric setting that decisions to restraint are taken without any warning or preparation. The majority of such incidents have a period, a lead-up period, during which things can be diffused. Unfortunately, the protagonists in the ward, patient v staff, they are occupying different positions of power. The patient has no power. We want to moderate, reduce that by inviting and ensuring the community members to be present as an ally of the person who is threatened with harm. And that person will have the opportunity to help not only the patient, but also the staff in reaching for alternative management options. The same thing is applied in relation to the use of Mental Health Act. Mental Health Act, the imposition of it, once again, is a slow process. It's only a minority of cases where individuals are subjected to the Mental Health Act without there being a period of consideration, deliberation, preparation. And we want not only a family member, but also a member of the community to be present in assessing, in understanding, and in codifying the risks which the psychiatrist and the social worker might be considering. And that third-party intervention in these processes, we believe, will reduce the use of restrictions as well as the use of the Mental Health Act. The key to it is understanding that every individual's actions, whether in psychiatric settings or otherwise, those are contextual and they are meaningful. We, as psychiatrists and psychiatric practitioners, fail to understand that meaning or take into account the context and the narrative of the patient that we are seeing and that we are threatening with harm. We want to break that open. We want to make that more public. We want to ensure a level of engagement from our communities in that process. And through that, we are confident we will be able to not only help individuals who find themselves trapped in that situation, but also the staff who are engaging in what they themselves consider to be an inhumane practice. This is a project that is been funded and that is being implemented in Wandsworth. I invite all of you who have an interest in this area to come and join us, to help us, to be collaborators in this kind of work, to be involved in discussion and in challenging the local practices, and to be part of the project, to be the community agents who will actually bring about the change in this area and change the mental health system from outside. I will stop there and give people an opportunity to raise any points that they may want. Thank you.